Bridge. So we are using the PDF file. I've just got some presenter note there to remind myself about some of the figures that I'm going to go through in the presentations, but hopefully my memory holds. Okay. So I'm here to talk to you about alcohol and medication use in the elderly. And before I start, just going back to the global prevention guidelines for that Suzanne has just mentioned. When I look through that guideline, there isn't a lot that's mentioned about alcohol and medications, interactions, and risk of fall. So hopefully today I'm able to provide you with more information in terms of what's the recommendations that's currently out there. Okay. It looks like it doesn't like the. Okay, so I'll start off by talking about alcohol intake in the elderly. So there are various reasons why the older adults drink alcohol. I think we are familiar with some of the reasons, and these include the belief of health benefit. So there's a lot of conflicting information out there online about the benefits of alcohol, including heart health. But the World Health Organization has concluded that drinking alcohol should never be encouraged as a form of preventive medicine. And here in Australia, the Cancer Council of Australia has stated that alcohol use increases the risk of all forms of cancer. Now, the other common reasons for alcohol use in the elderly is to remain sociable in celebrations and events, especially in those that are in retirement home. So I know that with our online audience today, there are a few of you who were from retirement homes, so perhaps you can comment a little bit more about that later. Now, the other reasons include depression, loneliness, the loss of a partner or a loved one, and some are just drinking for enjoyment, which could potentially lead to dependence. So let's have a look at the pattern of alcohol use in the elderly. With the latest National Drug Strategy Household Survey, it's showing that the age group that are most likely to drink on a daily basis are those aged 70 and over. So 12.6% of these population were drinking on a daily basis, and men were much more likely to drink every day compared to women. With the low-risk drinking guidelines by the MHMRC that was revised back in December 2020, it states that to reduce the risk of harm from alcohol-related disease or injury, healthy men and women should drink not more than 10 standard drinks in a week and not more than 4 standard drinks on any one day or on any single occasion. So for example, if you've got a person who has had 4 drinks on a Saturday night, another 4 drinks on Sunday night, then they're only allowed another 2 for the rest of the week. And it's fairly important to remind our consumer out there or your patients that an average serve of alcoholic beverage is not necessarily equivalent to a standard drink. So take, for example, if you have a look at the average serve of red wine in a restaurant, that's approximately 1.5 standard drink. So here in Australia, 1 standard drink is defined as 10 grams of alcohol. It's slightly different in other countries. For example, in the States, 1 standard drink is approximately 13 to 14 grams of alcohol, depending on what resources that you're looking at. So coming back to the National Drug Strategy Household Survey, when we look at the lifetime risk amongst people aged 60 to 69, those who exceed the lifetime risk, which is defined as having more than 10 standard drinks in a week, has decreased slightly from 18.1 to 17.4%. But when we look at the single occasion drinking risk, which is exceeding 4 standard drinks on any one occasion, that has increased from 16.1 to 17.4%. Okay, so from 2010 to 2019. And this is looking at those aged 60 to 69. Now, I haven't got it up on my screen, but the pattern is not any different from those aged above 70, where the proportions exceeding the single occasion drinking risk has increased from, if my memory serves me right, 7.7% up to 8.2%. So it is a concern in terms of elderly who have said that a low risk drinking limit on a single occasion. Now, when we look at the MHMRC low risk drinking guideline, that is obviously designed with healthy adult in mind, and it may well be on the generous side when we look at the older populations, because we are well aware that there is physiological changes with the older populations, where there's a decrease in the rate of alcohol metabolism and a change in body composition. In Australia, we do not have a specific guideline for drinking limits in the elderly, but when I look elsewhere in the States, we have the American Geriatric Society guidelines, which recommend not more than 1 drink a day with a maximum of 2 on any single occasions in the elderly. And we also got the US National Institute of Aging, where it's more general and they're recommending not more than 7 drinks in a week. Again, not more than 1 to 2 on any given day. Now, over in Canada, we have the Canadian Coalition for Senior Mental Health. So they're recommending not more than 1 drink per day, okay, with not more than 5 drinks in a week. Actually, before I move on, are they seeing what I'm seeing on the screen? Yeah. Okay, but this one here.
Well, we just can't see.
Okay, all right, no worries, that's okay. So, so with the Canadian guideline, it's not more than 1 drink per day with not more than 5 in a week. And for men, it's not more than 1 to 2 drinks a day with not more than 7 in a week. And then we've got the UK Public Health Agency. So within the UK, they're recommending for elderly women, it's not more than 2 to 3 units per day, and for men, 3 to 4 units per day. Now, notice here that in the UK, the guideline is quoted in units. So to put it in perspective for you, 3 units of alcohol is approximately equivalent to 1.5 standard drink here in Australia. So it's pretty consistent with the other guidelines that are available in other countries in terms of drinking limits in the elderly. So let's move on to talk about alcohol and medications interaction. In Australia, approximately 15 to 20% of Australians aged 65 or over suffer from at least 1 chronic condition. And this figure that I've got on the right-hand side here on the percentage of people by number of medication dispensed, this is data obtained from the Primary Health Network. And you can see that almost all of the elderly population aged 75 and over are on at least 5 medications. And in fact, about half of them are on 7 or more medication. And in Australia itself, as I mentioned earlier, the populations that are most likely to drink on a daily basis are those aged 70 and over. And amongst those who are currently drinking, 4 out of 5 of men and women were taking some form of a medication. So you could see when you put these two together, you see that how the risk of alcohol and medications interactions could be a significant issue in this population. So a more recent study done in Ireland looking at community dwellings, older adults, so people who are still living in the community, who drink within the light to moderate limits, who drink within the light to moderate limits. And when you look at their the potential interactions between alcohol and medication, is showing that a lot of these individuals are actually taking 1 or more medications that could potentially interact with alcohol. So this is a very large study done in Ireland, the Posamino study. And for those of you who are interested in a list of medications that could potentially result in serious adverse events when taken with alcohol, it's worthwhile looking into this study, and I've provided the link at the end of this presentation. So this is a study that was done here in Australia. Okay, so a pretty recent study published in 2021, looking at the drinking status by age classification and gender. And you can see that they're dividing the participants into 3 groups of older adults. So you've got a young old, the older old, and the oldest old. And approximately half of all these older populations are classified as low-risk drinker. So we're really going to get onto these people if they're taking medications that potentially interacts with alcohol, resulting in adverse outcome. So some of the concern that we have in terms of potential harm include sedations and dizziness, which of course leads to injuries resulting from fall and motor car accidents. It could also result in cognitive and psychomotor impairment, as well as gastrointestinal bleeding. So why is it important, and why are we here talking about these today? A study published in 2005, and in fact, I think with the injury matters report that Rosine talked about earlier on, we know that alcohol-related fall were probably one of the most common conditions leading to hospitalizations among the older populations. And exposure to medications that involves the central nervous system are associated with a further increase in risk of fall, where there's a 19% increased risk in fall and 8% increased risk of injurious fall at 4 years mark. So they're actually following these populations and look at the risk of fall currently and 4 years later. So there's another study in Finland that shows similar findings. So these are looking at men and women that present at the emergency department with fracture, and 21.5% of men and 7% of women has used alcohol in a 24-hour prior to the fall, and 2/3 of these patients are actually using 4 or more medications, and interestingly enough, 30% of them are using medications that has a sedative effect. So when you look at drugs that are likely to result in increased sedations, the benzodiazepine, which include diazepine and nitrazepine, are significantly associated with increased risk of fall. So for example, if you look at nitrazepine here, those that are taking this class of benzodiazepine are 2.3 times more likely to fall compared to the control group. And other drugs of class that has that could potentially significantly increase risk of fall include the SSRI antidepressant and mirtazapine. So what I'll do over the next 10 to 15 minutes is to talk to you about alcohol and medications interactions that could increase risk of fall. And I've spoke about the benzodiazepine, and of course we've got other group of drugs, including the opioids, antidepressant, antihypertensive, and the nitrates. Now, what we currently have in place to prevent adverse outcome from alcohol and medications interactions are the consumer medications information. So these are the leaflets that's available in the medications that comes with the medications, I should say. And the thing with the CMI is it often just offers very generic advice on, for example, if you choose to drink, then have a chat with the doctor or the pharmacist, okay, or just a general statement about not to be taken with alcohol. Again, it's very interesting on how people interpret this statement, because when you talk with your consumer out there about medications that are not to be taken with alcohol, some are under the assumptions that it's not to be taken with alcohol. So in other words, as long as I'm not drinking alcohol when I'm swallowing the pill, then that's fine, right? But that's not the case. So what we're referring to here is not to be taken with alcohol for the entire durations of treatment. Okay, so we need to raise that awareness. And we do have what we call the cautionary label that's attached to the primary container of the medications. That's the CNA level 1 and 2. Level 1 are mainly for medications that could cause drowsiness if taken with alcohol. And then level 2 are for medications where they need to completely abstain from alcohol while on that medication. So let's start off by talking about antihypertensive. So antihypertensive are one of the top 10 drugs by prescription count on the PBS. And these include medications such as ramipril, perindopril, amlodipine, just to give you a few examples. And the way that this drug works to reduce blood pressure is by dilating the blood vessels. Okay, so they are very potent vasodilator, and as a result of that, it potentially result in orthostatic hypertension, dizziness, and fall. So for individuals who choose to drink while being treated for their hypertension, it's recommended that do not exceed the low-risk drinking guideline, and it's very important to monitor their blood pressure to see how these medications affect them, okay? And then decide whether they need to cut down on the alcohol consumption. And then we've got the sedating antihistamine. So these include dexclofenamin, diphenhydramine, and probably you are more familiar with the brand name. So these are medications such as Phenergan and Ploramin. Okay, so these are a very highly sedative group of medications, and it potentially results in increased drowsiness, fall, and decreased motor skills. Now, in terms of the sedating antihistamine, I guess first of all, it's very important to review the ongoing need for these medications, right? So you've got to ask the patients why they're taking these medications. Okay? If they're using it for hay fever or allergy, then perhaps the non-sedating antihistamine would be a much better option if they choose to continue drinking. But if they are taking it for any other indications, then it's best to avoid alcohol. Then we've got the nitrates. So the nitrates are commonly indicated for treatment of coronary artery disease and for people with ischemic heart disease. Again, they're a very important group of vasodilators. So it comes with the increased risk of orthostatic hypertension, dizziness, and fall. And with the nitrate, it is very important to remind the customer or the patients to stand up slowly from sitting, because there could be a sudden drop in blood pressure and they could end up falling over. And again, very important to ascertain the effects of alcohol on this medication. Now, coming back to the benzodiazepine, so we said that benzo is one of the group of medications that are most likely to increase risk of fall amongst the elderly population on its own, and of course that risk is further increased when they're taken with alcohol. So the recommendations again is to review the ongoing need for these medications, because often benzodiazepine should not be used over a prolonged period of time due to the risk of dependence, and often it's indicated for short-term treatment of anxiety, panic disorder, or insomnia. Okay, so talk to the patients whether there's a need to stay on the medications, and if they are to remain on benzodiazepine, then it's very important to avoid alcohol. Then we've got the opioid analgesics. So these includes drugs like morphine, oxycodone, codeine, and then we've got tapentadol and tramadol, which are very commonly used in an outpatient setting as a form of analgesic in patients that had orthopedic surgery such as hip replacement or knee replacement. This is a highly sedating group of drugs. So again, if there needs to be on opioid analgesic, best to avoid alcohol. Right, next I'm going to move on to the antidepressants. So there are many different classes of antidepressants. It's not just the SSRI, the TCA, and the mirtazapine or the MAOI, but I'm just focusing on these four classes of antidepressants because of the risk of fall associated with these drugs. So all these antidepressants increase the risk of drowsiness and sedation, but with the monoamine oxidase inhibitor, which is the phenelzine and tranoscypramine, there is the risk of what we call a hypertensive crisis when you combine them with alcohol, and we're referring to alcohol that contains tyramine. Okay, so for example, beers, Chianti, vermouth, sherry. So all these alcoholic beverages contain tyramine. Now, the problem of combining these drugs with alcohol that contains tyramine is it could result in what we call a hypertensive crisis, okay? Because the way that this drug works is it inhibits the breakdown of monoamine oxidase inhibitor, and when you combine these drugs with alcohol containing tyramine, they get a sudden spike in the blood pressure. They would experience severe headache, and there's potential of intracranial hemorrhage, okay, or bleeding. So with individual who needs to be who are on phenelzine and trinoscypramine, it is important to avoid alcohol during treatments and for 2 weeks after ceasing treatment. Okay, but if they choose to continue to drink, then there's that limit of 1 glass of wine per day. Okay, that's the absolute maximum limit. Okay, and 13 grams of alcohol is enough to trigger a hypertensive crisis in these individuals, and we know that 1 standard drink is about 10 grams of alcohol. So it's very important to stick to that limit. Now, with all the other antidepressants, it's very important to get the patients to watch out for signs of drowsiness and dizziness. And again, if they choose to drink, then the recommendations is to limit it to 1 drink per day for women and 2 for men. Now, because of the time constraint, what I'm going to do is I'm going to briefly talk about other medications that could potentially interact with alcohol and increase risk of fall. And these would include baclofen, which is a muscle relaxant used in the treatment of muscle spasms in patients with multiple sclerosis. And then we've got levodopa with carbidopa, pramipexole, and amantadine. So all these 3 are used in the treatment of Parkinson's disease. And we've got gabapentin, which is an anti-epileptic, but in the elderly populations, they are more commonly used for neuropathic pain. Right? So all these medications increase risk of postural hypertension and drowsiness, and therefore, if you combine them with alcohol, the risk of fall is significantly increased. Okay, now the next few slides are on medications that could potentially interact with alcohol. It doesn't result in increased risk of fall, but rather some other adverse outcomes. So I thought I'll include it in here for completeness. So first of all, we got the anticoagulant, commonly known as the blood thinner, and these are drugs like warfarin, apixaban, rivaroxaban, and dabigatran. And these 3 drugs are sometimes commonly referred to as the DOAC or the NOAC. This stands for direct acting oral anticoagulant or novel oral anticoagulant. Now, the problem with combining anticoagulants with alcohol is the increased risk of bleeding. So we recommend individuals who are taking anticoagulant and who choose to continue drinking to limit their intake to a maximum of 2 drinks a day for men and 1 drink a day for women. And it is very important not to exceed the single occasion drinking limit. In other words, not more than 4 drinks on any single occasion. Okay, and to monitor for signs and symptoms of unintentional bleeding, and these would include, for example, bleeding gums when they are brushing their teeth, which is difficult to stop, or unexplained bruising, especially in the elderly. Next, we've got the antiplatelets, so low-dose aspirin, very commonly used as secondary preventions of myocardial infarction or heart attack. The problem with combining low-dose aspirin with alcohol is the risk of gastrointestinal bleeding. But having said that, the risk of GI bleed are relative, so it depends on a whole range of other factors such as durations of treatment, whether they're on any drugs that increase risk of bleeding, any past history of GI bleed, and the amount of alcohol consumed. Now, I guess the good news is there's no consistent evidence out there that mild to moderate alcohol use significantly increase risk of GI bleed, but it is important to review that risk based on the risk factor that I've listed here. Okay, non-steroidal anti-inflammatory drug. I'm sure you're all familiar with this group of drugs. So these are drugs including ibuprofen, naproxen, diclofenac. And the problem with these groups of drugs, for example, with ibuprofen, which is marketed under the brand name of Nurofen, you can get it from the supermarket. So the prescriber, the pharmacist might not necessarily know that the patients are taking Nurofen. Okay, so with these drugs, again, what we're concerned about is the risk of GI bleed. Very similar with the low-dose aspirin, the risk will depend on individual risk factor. But if the patients are taking non-steroidal anti-inflammatory over a prolonged period of time, and a classic example of this would be elderly patients who has got rheumatoid arthritis who get put on naproxen, okay, before the other anti-rheumatoid drug starts to kick in for a good 6 months. Okay, so for these individuals who are on long-term treatment with NSAID, it's best to avoid alcohol. But for individuals who are using NSAID on a very occasional basis, for example, for a muscle sprain, then I guess the risk of GI bleed is very unlikely. Okay. Now, moving on to medications for type 2 diabetes. So there are lots of different groups of medications used for treatment of type 2 diabetes. But today I want to talk about the sulfonylurea and insulin, because these are the two groups of drugs that are most likely to result in hypocrisis or hypoglycemic crisis, low blood sugar level. Of course, insulin is used for treatment of type 1 diabetes as well. Now, the problem with combining alcohol and with these drugs are the risk of hypoglycemia, because alcohol inhibits glucose output by the liver, and on top of that, it tends to mask the warning signs of hypoglycemia. So patients tend to get some warning signs such as sweating profusely, trembling, dizziness, and racing heart, but these could be masked when they are taking alcohol. So they're not aware that the blood sugar level are dropping to a dangerously low level. So the recommendations for individuals who are on these drugs and who choose to drink, again, is to not exceed the low-risk drinking guideline and make sure they don't drink alcohol on an empty stomach, because having some food before drinking would help to slow down the rate of alcohol absorption. And of course, it's wise to have some short-acting glucose handy in case they start to get that warning signs of hypoglycemia. For example, jelly beans would be a very good source of short-acting glucose. Okay, so at the very first sign of hypoglycemia, make sure they start to replenish the blood sugar level with one of these short-acting glucose to get the blood sugar level back up. Okay, now we've got a GP in the room with us here today, and I guess methotrexate is one of the drugs that are commonly flagged by GP in terms of interactions with alcohol because of the known risk of liver toxicity or hepatotoxicity. Having said that, though, the risk of liver toxicity with combined use of alcohol and methotrexate is inconclusive, and a lot of the study seems to point to point us in the directions that these risks would depend on the patients themselves. Okay, so the level of alcohol intake, any family history of liver disease, and so on. But the Australian Rheumatology Society recommend that if the patient is on methotrexate, then they should limit their alcohol intake to 1 to 2 standard drinks once or twice a week, and definitely avoiding more than 4 standard drinks on any single occasion. Next, we've got the anti-infective. So I've listed down the anti-infective that needs to be avoided, okay, that where alcohol needs to be avoided, I should say, during treatment. And these include the isoniazid, which is antibacterial used in tuberculosis treatment, and patients normally need to be on these drugs for at least a good 6 months. I guess it's easy enough for us sitting here and say, right, you're going to stop drinking while you're taking the isoniazid tablets, but it is not as straightforward as that. As you could probably testify to it, I guess, but it's still important to tell the patients that if you choose to drink while taking these antibacterials or antifungal, then there's that risk of really nasty side effects, which is what we call a disulfiram-like reactions, where they get racing heart, they get nausea, vomiting, and flushing. Okay, so it's important to raise that awareness. And in fact, with the metronidazole, not only does they need to refrain from alcohol, but it's also important to stop drinking for 24 hours after finishing the course of antibiotics. Okay, again, I know we're talking about medications and alcohol, but I thought I'll include the slides on herbal supplements. So we've got plenty of people out there who are using herbal supplements for various reasons. But bear in mind that some herbal supplements like your chamomile, valerians, and St. John's wort could potentially increase the drowsiness and sedations associated with alcohol, and therefore increase risk of fall or other alcohol-related injury. So where to from here? A local study, in fact, this study done by Wilkinson and her group in Western Australia showed that 90% of the participants were actually open to having a conversations with GP about alcohol and medications interactions, and about 50% of men and 65% of women said that they're happy to have that conversations with their community pharmacists as well. Okay, so I guess the vibes out there is they're pretty open to have that discussions when there is an opportunity to do so. We do have a screening too for alcohol and medications interactions in the elderly population. So that is the Australian Alcohol Related Problems Survey, or commonly known as the AARPS. Now, this is a screening tool that was developed back in, I think it was 2015, if I'm not wrong, in partnership with University of California. It's an online screening tool that is based on a very complex algorithm. So there's about 180 algorithms in the software itself that work out the risk of alcohol-related harm based on the patient gender, age, their medical conditions, and the medications that they're taking. Okay. But I guess the downside though is that the AARPS survey is not widely available for use in in a lot of the health setting. And in fact, when I tried to assess this survey, it's actually a licensed product that has been incorporated into the Older Wiser Living, which I'm going to come to in a sec. So Older Wiser Living is the programs that look at minimizing alcohol-related harm. So where to from here? We do have some services that are readily available to prevent adverse outcome in individuals who are drinking within low-risk drinking limit and who are also on medications that are likely to increase adverse outcome when taken together with alcohol. And these include services such as the HMR, which is home medication review, for people living in the community. And then we've got the RMMR, which is the residential medication management review for people living in aged care facilities. So referral is generally through the GP, right? So GP will write out a referral for this service, and then a pharmacist will visit these patients either at their home or in the residential aged care facilities to go through their medications. And I guess one of the things that pharmacists look out for is their alcohol intake and potential interactions with the medications that they're currently on. And we certainly do need more resources to raise awareness on alcohol and medications interaction, not just at the consumer level, but within the health professionals as well. Okay, and we do have a few allied health professionals with us here today, and I think it has to be a multidisciplinary approach. So we've got physios, OT, who are commonly seeing patients coming in with a fall in the hospital, and so perhaps that's a good opportunity to talk about alcohol and medications interaction. And there need to be, I guess, a referral pathway or to appropriate intervention. So these Older Wiser lifestyle program that I spoke about in the previous slide, this is actually a program that was developed by Peninsula Health in Victoria, a very, very successful program looking at minimizing harm from alcohol, specifically in the older adults populations. And there are two arms to this program, which is the so-called the early intervention arm, which are people drinking within the low risk limit, and then they've got the treatment arm, which are people who are drinking at a harmful level. So this program here uses the AARPS survey to work out the individual risk of alcohol-related harm, and they will get an individualized report on the interventions that are relevant to that particular patient. Okay. So a very successful program in Victoria, and hopefully we could have something similar here in Western Australia. Okay, the next few slides are on useful resources that you might like to refer to. This first one is the Pesomino study that I've referred to, and this group came up with a list of medications that could result in potentially serious harm in terms of alcohol and medications interactions. Beg your pardon, it should be the second link here. So this first one is actually the treatment menu for the Auto-Wiser Living program. So if you're interested, that's the link there. And then what I've got on the next slide is the drink aware fact sheets, which is fact sheets provided to consumer on whether it's okay to drink alcohol while they're on the medication. Okay, that brings me to the end of the talk. Any questions?
That was so interesting. Thank you, Yaping.
No worries.
I just wanted to I can do a bit of a clarify around Drink Aware. So there's Drink Aware UK and there's there's a similar organisation in Australia. So just be wary of the Australian one because it's very alcohol. It's like one of those harm minimisations disguised by alcohol industry efforts. So there is a bit of a distinction between those two. So probably if you're going to look at that, look at the UK stuff rather than the Australian, and probably go to the Alcohol and Drug Foundation website for more information about alcohol and other drugs as well. That was brilliant. Yeah.
Yeah, and I should probably mention that the alcohol, I guess, equivalent of the Drink Aware is the alcohol think again here in Australia. So if you Google alcohol think again, that's the equivalence of what we have here.
Yeah, that's so true. That's awesome. I actually am not aware of the OWL and all of those last few slides that you showed. So thanks very much for that. I'm going to have a look into that. That's really interesting.
Yeah.
Yeah. And I did have a question. I wanted to know if you knew anything about this, but when you were talking about the older adult guidelines being specific in different countries, do you know, I mean, I know in Australia we're having a hard enough time raising awareness of the guidelines as it is. How do countries like that navigate raising the awareness of the general population guidelines versus then older adults guidelines? I'm wondering if they struggle with that.
Yeah, that's a very interesting question. I think if you look at the older adult guidelines in the US, they're actually channeling it through to the older adult specific organizations like the National Institute of Aging. So perhaps we could look at doing similar things here in Australia as well. And in the Canada, they're actually channeling it through the older adult mental health organizations.
Yeah, that's a good idea. That's probably an advocacy space we could be in. Yeah.
So does anyone else have any questions?
Yeah.